We'll give everyone just another minute to join, then we'll get started. Alrighty. Good evening, everyone, and welcome to tonight's webinar. My name is Samuel Young. We have tonight Dr. Christina Kane and Priti Saha with us as well. Just a few housekeeping tips for everyone to note. There is a question and answer button that you guys can publish or post questions that you have throughout tonight's presentation. There will also be periodically polls for you to vote as well. And at the end of the webinar, there is a post-webinar survey that we would really ask everyone to take advantage of, give us some feedback. It'll help us out in future webinars. So with that, Dr. Kane, I will hand it over to you.
All right, good evening, everyone. Thank you for coming to our Zoom information series. And this is the ins and outs of shoulder pain part 2. And we'll be discussing rotator cuff injuries and treatment options. As Sam said, I'm Dr. Christina Kane. And I'm one of the orthopedic surgeons at Berkshire Orthopaedic Associates. Oh, Sam, having a little, we're good. All right, so just a little bit about me. I received my medical degree at University of Massachusetts Medical School in Worcester. I also completed my orthopedic surgery residency in Worcester at UMass. I then did a year of specialized training. I did a sports medicine fellowship at New England Baptist Hospital in Boston. So I do, Massachusetts is very near and dear to my heart, and I haven't really traveled very far. We also have a number of other providers at Berkshire Orthopaedics. We currently have 8 orthopedic surgeons on staff as well as a physiatrist. We have a large team of orthopedic surgeons specializing in many different areas of orthopedics, ranging from total joint replacements, trauma, hand surgery, and sports. We also have offices in Pittsfield, North Adams, and Great Barrington, so we provide services to all of the Berkshires. So just a quick outline. So we'll go over some brief shoulder anatomy, and then we'll jump into some very common shoulder disorders I see quite often in clinic. We'll start off with subacromial impingement, and then we'll go on to rotator cuff tears, and we'll talk about partial and then full thickness rotator cuff tears. So let's do our first poll question, Sam. Do you currently have shoulder pain? And then I'll just keep going forward. So let's start out with some anatomy of the shoulder. So the shoulder joint consists of bones, tendons, cartilage, and muscles that are all arranged around a joint to help produce a variety of different movements. The shoulder is a beautiful joint. It's one of the most mobile joints in the body. And the rotator cuff is a series of 4 muscles in the shoulder that form tendons and then insert in and around the joint and help stabilize the joint as well as move the joint. So
we actually have results if you are ready.
I am ready.
Cool.
So do you currently have shoulder pain? 84% of you currently have shoulder pain. So that's quite a bit. So I'm glad you've come to this talk. All right, so continuing on. So the shoulder joint is a ball and socket joint. So if you think about it, it's shaped like a golf ball on a tee turned sideways. So you kind of get an idea here, looking at the shoulder here, as well as the glenoid, and then the golf ball on a tee. It's made up of 3 bones. First, you have the upper arm bone called the humerus, or the ball portion of the joint. And then you have the shoulder blade bone called the scapula, this big flat bone here, which has a bony projection off of it called the glenoid. And this is the socket portion of the joint. This is a shallow dish-like part of the shoulder joint. You also have the clavicle, and then there's a number of bony projections that come after the scapula. One is called the acromion. That is the bone you feel right at the top of the shoulder. And that's it's a main player when we get to shoulder impingement. So here again is an x-ray showing a shoulder joint. You have the proximal humerus or the ball. You have your glenoid, which is the socket part, and that comes off of the scapula. Your clavicle, this is the acromioclavicular joint, and then here's the acromion, so the top bone. So because the shoulder joint is a very large ball with a shallow socket, it's a great joint. It affords us lots of range of motion. So we can do lots of range of motion with our shoulder that other joints don't allow us to do. But with this increased range of motion also comes increased stability, or increased instability. So it's one of the more unstable joints in the body, and therefore it's more susceptible to dislocation. So you can see this rugby player here dislocated his shoulder and is pretty, used to having to locate it back in. We have a large range of motion with our shoulder joint. We can flex it, we can extend it, we can abduct it or adduct it. That just means moving it to the side and back. And then we can, internally and externally rotate it. So let's go over some rotator cuff anatomy. So the rotator cuff is made up of 4 muscles that arise from the scapula and then insert onto the humerus or the ball. So there are 4 of them: the supraspinatus, the infraspinatus, the teres minor, and then the subscapularis. So the rotator cuff is a dynamic stabilizer of the shoulder joint, which just means that the tendons help stabilize the shoulder. So it keeps the upper part of the arm located in the socket. So it prevents the golf ball from falling off the tee. It's also one of the more commonly injured tendons. So let's start off with supraspinatus. This is the most common injured tendon of the rotator cuff. This helps you elevate your arm away from your body. So for example, your supraspinatus is very important for when you lift your arm. So if you were to grab something about a cabinet or to change a light bulb, that is you using your supraspinatus. The next one we'll go over is the infraspinatus, as well as the teres minor. These are very important for external rotation of the shoulder. So for instance, when you swing a tennis racket or a golf ball, you're using your external rotation, and that is your infra and your teres. Then the last rotator cuff tendon is the subscapularis. This is the one that's in the front of the shoulder, and this helps you internally rotate. So every time you reach into your back pocket or you're reaching to the back of the car seat, that is you using your subscapularis. I also want to touch a little bit on the subacromial bursa. So a bursa is a small pocket of fluid that acts as a shock absorber between bones and muscles and tendons in the body. And you do have a bursa underneath that top bone, underneath your acromion, called the subacromial bursa. So it is between the rotator cuff tendons and the top bone, and it's a lubricating sac. It helps the rotator cuff glide under that acromion and when you move your arm. Unfortunately, the bursa can be very prone to inflammation. It can cause pain, and we see this quite often in clinic. A couple of other structures that are commonly injured around the shoulder is the biceps tendon. So your muscle, your biceps muscle has 2 tendons that come off of it, and one of them inserts into the shoulder joint. So this can oftentimes be injured along with the rotator cuff. And then there is the labrum. The labrum is a structure in your shoulder that acts as a bumper. It helps deepen the socket or the dish-like portion of the glenoid to help keep your shoulder reduced. And this is oftentimes injured as well. And we see this a lot when we do shoulder scopes. All right, second poll question. Have you ever been diagnosed with a rotator cuff tear? All right, I will keep moving on. Okay, so the rotator cuff is a very common source of pain in the shoulder. We see this quite frequently in clinic. And rotator cuff disease is on a spectrum of disease, starting with the more milder symptoms and diagnoses of impingement range. And then on that spectrum, you can have a continuum of disease moving on to tendonitis, which is the inflammation of the tendon. And then that can progress further into a small or large rotator cuff tear. So let's talk about shoulder impingement first. So this is the first stage of rotator cuff disease and the most common cause of shoulder pain. Up to 65% of shoulder pain is caused by impingement syndrome. So in shoulder impingement syndrome, the rotator cuff tendons and the overlying bursa are pushed up against the acromion, and this happens when you raise your arm above shoulder height. So anytime you're moving up, there's potential for your cuff and that bursa to kind of impinge underneath this acromion. So, and the reason for that is that when you elevate your arm, the space that the rotator cuff has, as well as the bursa, narrows. And then that's how you get this impingement. It can be very painful, and we see this a lot. And this is commonly that term you hear, bursitis. When people describe that, they're explaining that this bursa underneath the bone here is getting inflamed, and that can be painful.
We do have some polls.
All right, let's see them, Sam. Have you ever been diagnosed with a rotator cuff tear? So about 1/3 of you have said yes. So yeah, I mean, that's a pretty good number. So we'll keep going on. All right, so what causes shoulder impingement? So this is not just, for older patients. This is a syndrome we see in both the old and the young. It's very common in young athletes as well as older patients. So in terms of athletes, any sport that you're going overhead a lot, so swimming, when you're doing free stroke, baseball, tennis, those are sports that are susceptible to shoulder impingement. In terms of other overhead activities which may make you prone to shoulder impingement, we think about painting, electricians, constructions, anything overhead. This can be a reason for shoulder impingement. However, you don't necessarily have to be doing a lot of overhead activities for this to happen, and sometimes shoulder impingement can happen for no apparent reason. So let's talk about the signs and symptoms of shoulder impingement. Oftentimes the pain comes on very gradually. You might often see some swelling and tenderness at the front of the shoulder, and then oftentimes it can radiate down the side of the arm. Generally in the early stages, you'll have intact strength, and your strength is normal. As it progresses, you may get pain and stiffness that is worse with overhead activities. You may have pain with lifting objects away from the body, and you may also have pain with lowering objects. As this progresses, you may have nighttime pain, and patients can find this very irritating. And when you get to the point of nighttime pain, that may be an indication for surgery. So let's go over some imaging. So in terms of diagnosing subacromial impingement, so x-rays are very good at showing us bony anatomy, and they're usually normal with subacromial impingement. Occasionally you can see a big bone spur. So here you have your ball and socket. Here's that acromion. That's that bone at the top which can impinge on the cuff and the bursa. And here you see a big bony spur projecting off of the acromion. But oftentimes you don't have a bony spur and you may still have impingement. MRIs and ultrasounds are much better imaging studies for us to look at the soft tissue structures of the shoulder, so we can better see the bursa, we can better see the rotator cuff tendons, and we can see if there's any partial tearing of your tendons. So if you have persistent subacromial impingement pain, your surgeon may end up ordering an MRI. So let's talk about treatment for shoulder impingement. So the goal of treatment is to reduce pain and then restore function to your shoulder. So first line treatment for the majority of cases of shoulder impingement are non-operative. We do a lot of physical therapy and activity modifications. So you really want to avoid doing any overhead activities, lifting heavy weights above your head, to kind of prevent you impingement on the bursa and that cuff. You can also take oral anti-inflammatory medications. The common ones are Motrin, Aleve, otherwise known as ibuprofen and naproxen. And I encourage you to avoid the name brands and save some money and go with the store brands. They're the exact same thing. You gotta be careful. These can cause belly upset, so stomach upset, so you want to take these with food. And then lastly, we have our cortisone injections. We do these quite often. It's a great way of directly injecting local anti-inflammatory into the problem area. So as opposed to taking a systemic NSAID for an anti-inflammatory, you're putting the cortisone right into the problem area. So it's a great way to target that inflamed bursa. So let's talk about some other treatment options for shoulder impingement, which have gotten a lot of hype in the media. The data is not necessarily there yet, but because it's so well publicized in the media, I thought we would talk about it briefly. I'm sure a lot of you have heard about PRP, otherwise known as platelet-rich plasma. And there's been a lot of famous athletes out there who have credited their return to competition to PRP, such as Tiger Woods. So let's quickly go over what PRP is. So when you have blood, there's a lot of different cells in your blood. One of them is platelets. Platelets help your blood to clot. The platelets also carry a lot of proteins on them called growth factors, and these help heal injured tissue. So how do you get PRP? So blood is collected from the patient, and then it's spun down in a centrifuge, separating out the platelets from the rest of the blood. And then with these platelets, there's a concentration of growth factors in there. So then once you have this concentrated platelets with growth factors, you then inject that back into the problem area or the injured tendon with the hopes of speeding up the healing process. So there's not much data right now supporting PRP use with rotator cuff injuries. Probably the most significant data currently is for its use with chronic tennis elbow, and there's some good data to support that. And because there's not great data yet, a lot of insurance companies do not pay for this. So a lot of times people are paying out of pocket, and it can get quite expensive. So let's continue to talk about treatment for shoulder impingement, and we'll get on to when will you need surgery for this. So if your symptoms are not relieved by the first line treatment, which is usually therapy, NSAIDs, and cortisone injection, and that goes on for many months, then you may be a candidate for a shoulder scope. So the treatment for shoulder impingement would be a shoulder scope with a subacromial decompression, which means that the surgeon goes in, they look at all your shoulder anatomy with a fiber optic scope, and then they use a series of instruments, usually a shaver or a burr, to help smooth down any bone spurs which may be causing impingement on that bursa and on the cuff. And at the same time, they'll also clean out that inflamed bursa underneath the bone there. So arthroscopic surgery is usually performed with 2 to 3 poke holes around the shoulder. In the back of the shoulder is usually where the camera is inserted, and then you usually have another poke hole on the side of the shoulder and the front of the shoulder where the surgeon will use instruments to clean, do whatever work they have to do inside the shoulder. So here's a picture of, this is a picture in the subacromial space. Here you can see my shaver. So this was a big subacromial spur causing shoulder impingement in this patient. So here I kind of took down a portion of that spur, and I'm just showing you how big this spur was. And then as I complete it, it's nice and flat now. And this patient got really great relief from this. So what does the recovery from a shoulder impingement surgery look like? It's a day surgery. You're in and out the same day. You're usually in a sling for comfort, and you can take that off as quickly as you would like to. Usually we want you out and doing pendulums and moving pretty quickly. And then you're in physical therapy that week or the next week. And generally patients feel pretty good in a couple months after this surgery. All right, last poll question. Have you ever had surgery for a rotator cuff injury? All right, so let's start talking about rotator cuff tears. So rotator cuff tears are a common cause of pain and disability in the adult population. The prevalence is pretty high. So in terms of a full thickness rotator cuff tear, people above the age of 60, about 1 in 4 will have a rotator cuff tear, and people above the age of 70 have about a 65% chance, or 2 out of every 3 patients will have a rotator cuff tear. There are different types of tears. There's partial thickness tears, where it's an incomplete tear, so some of it is damaged, but the other portion of the tendon is intact. Then you have full thickness tears, where it's a complete tear of the tendon separated from the bone. And so this is basically a big hole in the tendon. And then lastly, you have massive, which is when you have 2 full thickness tears. So you have full thickness tears with at least 2 or more tendons.
We do have poll questions if you're ready.
Okay. So have you ever had surgery for rotator cuff injury? So 93% of you have not. So that's good. It's always good to avoid surgery. And 7% of you have. So you're pretty familiar with everything I'm going through. All right, continuing on. So what are the 2 main causes of rotator cuff tears? So the first is an acute injury. So this is most oftentimes due to a fall. So you fall on an outstretched arm, or you're lifting something heavy like a suitcase, putting it into an overhead bin on an airplane. The second type of tear is a chronic degenerative tear. This is a tear from many years of wear and tear on the tendon over time, and these are more common in your dominant arm. And the chronic degenerative tears we more commonly see in older patients as well. So signs and symptoms of rotator cuff tears. So if you have an acute fall, you may experience a snapping sensation in the shoulder, and you may have immediate arm weakness. It sometimes can be quite profound. If you have a chronic tear, you may have kind of a gradual worsening of your symptoms. So you might start off having just pain with lifting your arm or lowering your arm to the side, and then it may progress to pain at rest or at night, and then you may have weakness lifting objects. So again, in order to see the soft tissue structures of the shoulder, we generally want an MRI to look at this. So here's an MRI of somebody's shoulder. As you can see here, the proximal humerus, the ball portion of the joint. Here is the glenoid or the socket. And then here is a rotator cuff muscle. And then as it comes across, inserting onto the proximal humerus here, it turns into tendon. This should be all covered here. So it should continue to insert here, and you see this big tear right here in the rotator cuff. The MRI is great for us to look at the location of the tear, the size of the tear, as well as the tendon quality. Is it a healthy tendon? Is it a degenerative tendon? It also gives the surgeon a really good idea if we are able to fix it. So what are the treatment for rotator cuff tears? Again, the goal for patients is to reduce their pain and restore their function. So for many tears, the first line treatment is still non-operative. So it's activity modifications, NSAIDs, PT, and steroid injections. What are the benefits of non-operative treatment for rotator cuff? Is that you get to avoid surgery, yay. You know, there's lots of complications that come with surgery. There's potential for infection, stiffness, prolonged recovery. However, there are cons to non-operative treatment. For instance, the size of the tear may increase over time, and we know from the literature that about 50% or more of full thickness rotator cuff tears will progress within 2 years. So you may have to get used to a new normal. You may not be able to lift as much as you were before overhead, and it may not be equivalent to your non-injured side. So when is operative treatment indicated? So if you, again, fail conservative treatment, if you go through PT and injection and you're still having pain, you're still having weakness, that is an indication for surgery. Other indications for surgery, significant nighttime pain, you can't sleep. The larger the tear size, so if you have a large tear size with good tendon quality, that may also be an indication for surgery. And oftentimes if you have an acute tear, so you have a specific event, you fell, and now you have arm weakness, we know from the literature that it's usually better to fix those people because they don't do well as well without surgery. And then there's different types of surgery that we could do. Generally, this is done through a shoulder scope. Sometimes the surgeon may have to do open. If it's a really large tear, they may have to make a small incision. And then at the same time of surgery, the surgeon will try to smooth out any bone spurs. If you have some disease of the biceps tendon as well as the labrum, they will likely take care of that at the same time as well. So what does rotator cuff surgery look like the day of surgery? So again, it's a day surgery. On the day of surgery, anesthesia will usually give the patient a block. So that's a regional block, and that'll at some point wear off in the middle of the night. You also get some general anesthesia with this. And again, The surgery is done with a scope using 2 to 3 portals. So here are some intraoperative pictures. So here's what a healthy rotator cuff tendon looks like. So here's your humeral head. Your rotator cuff tendon comes and inserts on its footprint on the humeral head. So there should be no gaps in this tendon. On this side, you can see humeral head, rotator cuff tendon, and there's a big full thickness tear right here. This hole should not be here. So, and then here's some more pictures. So this is a picture of an anchor. This is what we use intraoperatively to fix the tear. So here are some more pictures. So humeral head, this is all rotator cuff footprint. This should be covered. And here is the torn tendon. And this is what it looks like after it's been repaired. Here you can see there was probably an anchor right here, an anchor right here. And out of those anchors comes some string. It's like fishing line. And then that's how we retear the tendon back down to bone. So here are some pictures. So this is a picture of a big rotator cuff tear. So this is all rotator cuff footprint over here. The tendon should be coming and inserting here. You should not see this tear. Here's a shaver coming in and cleaning up this tear. It looks quite degenerative. So you want to definitely clean up these frayed edges before you repair it. And then here's what the anchor looks like going into bone. So we put the anchor into bone. And then out of that comes the fishing line or the suture. And then we have suture passing devices, which have a needle attached to it. It's much like a sewing needle. So with this suture passing device, we can go under the tendon and bite it and then push the needle through. And then that's how we get our suture through the tendon. And then we tie the tendon back down to the anchors with a series of knots. Some of them are knotless. And then now you can see that this tendon is covering the bone. There's no further gapping. So that's an excellent repair. So what does the recovery from a rotator cuff repair look like? So in general, tendon takes about 3 months to heal, and that can vary from patient to patient. Most patients are in a sling for 4 to 6 weeks, and then there's a pretty rigorous course of physical therapy that comes afterwards. So the surgeon's part is the day of surgery, and then the patient's part is much longer afterwards. And we know that patients who don't participate in PT do not do as well. So the therapy is very, very important. The therapist will start off usually just doing some passive range of motion, some pendulums. They'll help you move your shoulder. And then the patient will start active range of motion where they actively get to move their shoulder on their own around 4 to 6 weeks. And then strengthening is usually delayed till 8 weeks time. So overall, we kind of tell patients usually generally feel good, really good around 8 weeks. And I have to remind my patients you may feel good now, but the tendon is not fully healed. So you still have to take it easy. But in general, you'll most likely have a full recovery by 4 to 6 months. And the outcome from rotator cuff repairs are very good. The majority of patients have increased strength and decreased pain, and these are in the 90%. And that is all I have. Thank you very much. And with that, we will go on to questions. All right, so the first question is, are there side effects to cortisone injections? Yes, so there are. We don't really let patients get too many of them. I limit my patients to 3 to 4 a year just because they can have a cumulative effect on the tissues. They can degrade the tissues. And so I especially limit these in my young patients. Also, if you have diabetes, the cortisone can increase your sugars for the next 24 to 48 hours. So you have to be very careful with that. You need to monitor your sugars. So there are definitely side effects of the cortisone. Does the tear ever heal? So next question is, does the tear ever heal completely? Would I end up with surgery anyways? So if you have a rotator cuff tear, it may not heal. The goal with therapy is to get back your range of motion and decrease pain. And even though the tendon doesn't heal, you may still get an excellent outcome. despite the fact that your tendon doesn't heal. So would you need surgery anyways, even going through non-operative treatment? It's possible, but because a significant portion of patients do excellent with therapy, we generally use that as our first line. So sure, there is potential you may need surgery even after going through 2 to 3 months of therapy. But in general, patients do pretty good. The larger the size of the tear, less likely that, PT may fully resolve your symptoms. Okay. So the next question is, I was wondering if we could review what happens after the cortisone injection and what you can and cannot do after a cortisone injection. So I usually tell patients that after they have a cortisone injection, sometimes you feel sore for a day or two. So I just tell them not to overdo it for a day or two, but I don't really restrict them that much. So if you have an injection on a Wednesday, I usually say take it easy till Friday. No heavy lifting. You can go about your normal activities, but don't add anything into your routine. And then I say, it might be worth icing that night or the day after. So the next question is, how long do I need to be out of work after rotator cuff surgery? So that really depends on your occupation. If you have a desk job, then you're going to be back to work much, much quicker than if you have a very, labor intensive job where you're lifting heavy things like construction workers. So my construction workers, I'm not letting go back for 3 to 4 months. If you have a desk job, then a lot of times you can be back, 4 weeks or so. And sometimes even earlier if you don't have to do that much. So the next question is I sleep on my side and usually wake up in the morning with pain in that shoulder. Is this something I should have looked at right away? I don't think it's urgent, but certainly if it continues, I would have somebody look at it. I would definitely see someone who can do a good physical exam of your shoulder and possibly take x-rays. The next question, I was scheduled for surgery last year and delayed. Would I have to have a new MRI? So good question. Typically, the surgeon would want an MRI within a year and maybe even 6 months, just because the tear can progress. Things definitely can change within a year, so you may need to have a new MRI. All right, the next question is, any tips to help nighttime pain discomfort? That is the worst pain during the entire day. Yes, and this is super, super common, especially if you have a large rotator cuff tear. So a lot of people feel better if they're sitting up in a recliner or they have a bunch of pillows behind them. And then definitely avoid sleeping on that side. And then you can try to take non-steroidal at dinner time, right before bed, such as Aleve, to hopefully help with those symptoms. But if you keep having nighttime pain, I would definitely see somebody, because typically that is kind of at the end of the spectrum. So you might want to get evaluated for that. Okay, the next question is, I have 2 tendons with full thickness tears. One is 50%, and then a torn labrum. Is this going to lengthen my recovery time? What's good for pain management in the meantime? I can't take NSAIDs. So, yeah, so if you have a torn labrum, typically we're not repairing that with the rotator cuff. So if you have a rotator cuff tear as well as a torn labrum, oftentimes we're focusing on the rotator cuff. There's data showing that if you repair both the labrum and the cuff, patients get really, really stiff and don't have great outcomes. So if I have a patient with a degenerative labral tear, in addition to rotator cuff tear, I'm debriding the labral tear, just smoothing it out, and I'm fixing the cuff because that's what's going to get the patient the best results. What can you do if you can't take NSAIDs? So that's definitely a tricky situation. You can try Tylenol, and then I would definitely speak with your physician about other options. I have heard that people with diabetes can have issues with cortisone injection. Is that true? Yes. It can cause your sugars to be elevated for the day or two afterwards. So you really have to be monitored then pretty frequently. The next question, can you diagnose the type of injury without an MRI? So certainly physical exam is very important for diagnosis, but I would never, I can't really think of many situations I would indicate a person for surgery without obtaining an MRI. So there's a lot of times I send patients to physical therapy or I inject their shoulder with just x-rays and I don't necessarily need the MRI. But if I'm worried about a cuff tear, I'm thinking maybe the patient's going to need surgery, I always get an MRI. Next question, what if our normal activities are more intense, like mountain biking, which I would, okay. So can I keep mountain biking after I have an MRI or cortisone? Yes, you can. So I usually just suggest that you take it easy for that day or the day after. So I would not increase your activity level and just know that you may be a little bit sore the day after a cortisone injection, but you're not going to damage anything. And then I don't restrict anybody in terms of an MRI. Okay, so the next question. I often have pain with knitting and crocheting. It was suggested that maybe it was elbow pain, and it does help. Also, can rotator cuff issues cause pain in the neck? So there is this issue with shoulder spine, shoulder neck overlap. So a lot of times you can have shoulder pain that is coming from the neck and not necessarily the shoulder. That is very common. So anytime you go in to have your shoulder evaluated, the physician should be looking at your neck as well. So could the rotator cuff issues be coming from the neck? Not necessarily. If you have a rotator cuff issue, that's definitely the shoulder, but could you have shoulder pain coming from the neck? Absolutely. Okay, this is a great question. What happens if during surgery you find the tendon is frayed too much to attach? So if I go into surgery and the tendon is beyond repair, so it can't hold anything, I can't get it, I can't pass suture through it, it just falls apart, then what do you do? So there are, usually I know if that's going to happen by the MRI, from looking at the MRI, I kind of get an idea if I think the tendon will be able to be repaired. If I'm worried that I'm not going to be able to get a good repair, there are other things you can do. There's something called a superior capsular reconstruction, the SCR, and that's where you augment it with a patch. So if your tendon is poor quality, you could put a patch on it. And there's been pretty good results out recently. It's a newer technology, but there's been pretty good results out. There's also tendon transfers that you can do, but usually I have a pretty good idea before going to surgery if that's gonna happen. And I should say that there's lots of good data. So say you have a 2 tendon tear, say your supraspinatus and your infraspinatus are both torn. There's a significant, excellent data showing that if you're able to repair even one of those tendons, the patients have great outcomes. So if I can even repair just one tendon, I would prefer that over having to do a patch. So I think that this is probably asking me what I would do. The question is, older person with a degenerative tear, full thickness tear of both super and infra tendons, as well as a tear of the subscapularis, got hit in the arm forcefully. Pain minimal with range of, but range good but weak. And then you have as well as a biceps tendon tear. So what would I do? So if you're, so I think it depends a lot on the patient, how old you are. If you're not having pain but you're weak, so I would still consider weakness an indication for surgery. And certainly if you have tear of all three tendons, I would definitely consider surgery, even if your pain is minimal. But because if you're having weakness, that's an indication. Oh yeah, can it be repaired? Yes, it can be repaired, depending on what the tissue quality is, and you need an MRI to evaluate that. Next question, how much pain is there post-op and how do you treat it? So pain is very subjective and it differs greatly from patient to patient. Patients, in my experience, do pretty well post-op. The night of or the day after is the worst. Generally, the worst pain is when the block initially wears off. For my patients, I give a very short course of narcotics. And generally patients do very well with that. You may have to sleep upright in a recliner for a little bit to be comfortable to get some sleep at night, but generally patients do really well. Next question, how frequent does a dislocation have to occur for surgery to be recommended? I've had 4 dislocations. So it depends. So it depends on the patient. So if you're a young athlete and you've had 1 dislocation, if you're a football player or lacrosse player, to me, that's an indication for surgery, especially if we have an MR arthrogram showing you have a big labral tear. If you're not, if you're not an athlete and you've had 4 dislocations, so typically after 1 or 2 dislocations and therapy, if you're still dislocating, I would definitely get the MR arthrogram, see what pathology and injury you have going on the shoulder. And certainly I would be evaluated that, because if you've had 4 dislocations, that may be an indication for surgery. Next question, do people get infections with the patch? Certainly, people can get infections with the patch. Is the infection rate higher than a normal shoulder scope? I haven't seen much data on that, and typically we tell patients the risk of infection is typically 1% or lower. Next question, can diabetes hinder the healing process? It may. Certainly, the tendon could take a little bit longer to heal, and sometimes in patients with a larger tear or who have diabetes, sometimes we will augment with a patch just to promote more healing. Next question, I fell about 1.5 years ago. My shoulder still hurts a little. Can physical therapy work alone? It depends on the injury. I would have you definitely be evaluated, but physical therapy can work wonders, even if it's, a while after the injury. Is it better to see an occupational therapist or a physical therapist for the shoulder? I generally send my patients to a physical therapist for shoulders. Next question, great question. What's the indication for a reverse shoulder replacement? So the indication for a reverse shoulder replacement is advanced rotator cuff disease. This is when your rotator cuff is completely torn, it's not working, and you have severe arthritis of the shoulder. And if the rotator cuff is torn, you're not eligible for a regular total shoulder, and you need to have a reverse, because that way we can use your deltoid to get arm elevation as opposed to your rotator cuff. So if you have a decent sized rotator cuff tear, rotator cuff arthropathy, which is the arthritis that comes after rotator cuff tear, you would be a candidate for a reverse shoulder replacement, not for an anatomic. Any other questions? Well, Sam, are we all good? I think people have answered all the questions. I'm not seeing any more pop up.
Looks to me
Thank
like we
you.
are.
Thank you
Oh,
for
wait.
coming.
Looks like we have one more. Oh, never mind. Somebody's just saying thank you in the Q&A tab. Looks like we're all set.
Thank you so much, everybody, for coming. Have a great evening.
Thank you, Dr. Kane.
Will the presentation be available for later?
Yes.
Yeah, it will. Yep.
Yes.
All right,
Alrighty.
everybody.
We will let the participants know whether it'll be on our website or the YouTube connection. We'll let them know.
Okay, excellent. Thank you.
Thank you, everyone. Have a great rest of your evening.